So this is the first one, that maxillary lateral incisor. And as I mentioned, what are the clinical characteristics we're looking for? Well, when I look at this case, of course, I could say, let's take the tooth out. Let's allow this to heal and come back as an early implant placement. Cannot go wrong. Cannot go wrong with an early implant placement approach. But if the clinical conditions satisfy an immediate implant placement, then that's the way I would like to go, because there are huge patient-centered benefits in being able to take the tooth out and place the implant and, if possible, provide the patient with an immediate replacement. Big patient-centered benefits. So in this case, we have a thick gingival phenotype, clearly. From the CBCT, you see it's a thick bone phenotype, especially in that coronal region. The facial bone is intact. There is absence of any infection of any description. And there is good apical and palatal bone to allow an implant to be placed with stability. So here we can adopt or recommend to the patient a type 1A approach, immediate implant placement and immediate restoration. Of course, it's not immediate loading. We take the tooth out of full functional loading, but it's an immediate restoration protocol. So a flapless extraction of the tooth is undertaken. The implant is then placed with appropriate guides. And today, of course, we can use the digital workflow and 3D printed guides to help us with this, making sure that the implant is in the correct position and maintaining that minimum 2 millimeter gap between the implant and the shoulder. Now, at this stage, this was done some time ago, and this is a conventional approach. So we've taken an index of the implant, and once that's done, then the buccal defect has been grafted after the healing abutment has been connected. So you can see the completed procedure. And this is an immediate loading protocol. So the patient went back to the referring prosthodontist to have a provisional crown connected based on the index of the impression that was taken, of the implant that was taken at the time of surgery. So this is the 1 week follow-up. The resorbable sutures were used to stabilize the soft tissue margins, and now they have resorbed and have come away. That was 1 week, and this is 3 months. You can see clearly the provisional restoration in place, and everything is going well. And then the 3-year outcome. So a very nice outcome for this patient, maintenance of good soft tissue form, both from the facial aspect, and when you look at the middle image from the occlusal aspect, maintenance of good contour of the ridge, and the CBCT control taken at 3 years confirms that we have reconstructed a thick facial bone wall. It's now, as I mentioned, in the new biomaterial. The biomaterial is the new facial bone wall, and the soft tissue then is supported by the newly reconstructed facial bone. So again, no reason to expect that an implant like this would not remain stable, both functionally and aesthetically, with stable soft tissues over a period of time.